Hi, my name is Fernando Pisco Mendoza. The topic for today is combine Nivolumab and Ipilimumab or Monotherapy in Untreated Melanoma. First, definition. Melanoma is a type of skin cancer which forms from melanocytes. Melanomas are usually caused by DNA damage resulting from exposure to ultraviolet UV light from the sun. Genetics also play a role. What is Ipilimumab? It is an anti-cytotoxic T lymphocyte associated antigen for CTLA-4 antibody, as to regulate anti-tumor immunity, and was the first agent to be associated with an improvement in overall survival in phase 3 study involving patients with metastatic melanoma. Now a video.
My name is Rich Joseph. I'm a medical oncologist at Jacksonville, Florida. My clinical expertise is in cutaneous malignancies, including melanoma and other skin cancers, and I also treat urinary malignancies as well. So melanoma is distinct from other skin cancers in that it is usually a proliferation of pigmented cells, although not always. Melanoma can also originate in different parts of the mucosal tract, including the head and neck, as well as the GI tract, as well as on the bottoms of the palms of the soles, which usually doesn't occur in other types of skin cancers. Melanoma is the most deadly form of skin cancer because it is the cancer that is most likely to spread to other organs. Other types of skin cancers rarely spread from outside the surface of the skin, and the ability of the melanoma to metastasize makes it most deadly. And a stage 1 melanoma has a cure rate of about 95%. So if you catch it early, that's great. A thicker melanoma is something that is still in the skin, that has not spread to the lymph nodes or the rest of the body, still has a pretty high chance of cure if catching it early, somewhere in the range of 70 to 80% chance of cure. A stage 3 melanoma is when the melanoma has escaped from the skin and gone to the lymph nodes. And we divide stage 3 into stage 3A, B, and C, depending on how many lymph nodes are involved. And the cure rate there drops all the way down as low as 20%, many lymph nodes are involved, and as high as 60-70% only one lymph node. Stage 4 melanoma is a melanoma that has left the lymph nodes and gone to distant parts of the body. And there, the survival is much less. The overall average median survival is, talking in the order of months to maybe a year or so. However, those numbers are getting better with the therapies. I see melanoma patients usually at 2 phases. The first phase is if they are diagnosed and they have a lymph node that is positive. Traditionally, the lymph node is removed by the surgeon, and then they come to see me to help them prevent the melanoma from recurring in the rest of their body. And at Mayo Clinic, we have several clinical studies that are geared towards preventing melanoma from spreading to the rest of the body, which we call stage 4 melanoma rather than stage 3. Melanoma does predominantly exist in an older population. However, the amount of number in the younger population is much higher than other types of cancers. We still have a long way to go to eradicate melanoma or to cure the majority of the patients. But before the last 5 years, we were talking about getting responses and helping maybe 5 to 10% of patients. Now we're moving that bar up to anywhere from 20 to 50% of patients, causing them long-term remissions, which is a huge step forward, but obviously leaves us with another 50% to improve upon as well. So long way to go before we
Application in medicine. 2 anti-progranulin DEC1 PD-1 antibodies, Nivolumab and Pembrolizumab, were approved by the Food and Drug Administration in 2014 for the treatment of metastatic melanoma after progression during Ipilimumab treatment, and in patients with BRAF mutated melanoma after progression during treatment with BRAF inhibitor. These antibodies were associated with objective response in 30 to 40% of patients, with the majority of response being durable. 2 phase 3 trials have shown superior efficacy of Nivolumab as compared with chemotherapy in previously untreated patients with wild-type BRAF tumor or in patients with either mutant or wild-type BRAF tumors after progression during Ipilimumab therapy, and in patients with tumors positive for BRAF mutation after progression during treatment with BRAF inhibitor. The median progression-free survival was 6.9 months, 95% confidence interval CI, 4.3 to 9.5 in the Nivolumab group, 11.5 months, 95% CI, 8.9 to 16.7 in the Nivolumab plus Ipilimumab group, and 2.9 months, 95% CI, 2.8 to 3.4 in the Ipilimumab group. Significantly longer progression-free survival was observed in the Nivolumab plus Ipilimumab group than in the Ipilimumab group. Hazard ratio for death or disease progression 0.42, 99.5% CI, 0.31 to 0.57, P less 0.001 in the Nivolumab group than in the Ipilimumab group. Hazard ratio 0.57, 99.5% CI, 0.43 to 0.76, P less 0.001. Cons. The most common adverse events in the Nivolumab plus Ipilimumab group were diarrhea in 44.1% of patients, fatigue in 35.1%, and pruritus in 33.2%. The incidence of treatment-related adverse events of grade 3 or 4 was also higher in the Nivolumab plus Ipilimumab group, 55% than in the Nivolumab group, 60.3%, or the Ipilimumab group, 27.3%. Conclusion. Among patients with previously untreated advanced melanoma, we found longer progression-free survival and higher rates of objective response with Nivolumab alone and with the combination of Nivolumab and Ipilimumab than with Ipilimumab alone. The management of adverse events with the combination therapy suggests that it can be used safely and in a broad range of clinical settings. Now another video.
I'm going to be speaking about the results of a phase 3 clinical trial called Checkmate 067, which was an efficacy comparison of Nivolumab alone, Ipilimumab alone, and the combination of the two in patients with metastatic melanoma. In background, I think many of us are aware that there are several positive and negative checkpoints that control the immune response. CTLA-4 and PD-1 are two such negative checkpoints. They represent distinct and complementary pathways that negative regulate tumor immunity, and that provides a rationale for simultaneous blockade of both targets. Both of them have been shown to impact overall survival in melanoma. Actually, it was just 5 years ago that my colleague behind me, Dr. Steve O'Day, stood on the same podium introducing Ipilimumab as the first medicine ever to improve overall survival in melanoma.
Nivolumab was just shown to improve overall survival, the PD-1 blocking antibody, and we had conducted both phase 1 and phase 2 studies of this combination, which showed an unexpectedly high response rate of about 53% in the phase 1, 59% in the phase 2, with 2-year overall survival rates ranging from 79 to 82%, depending on dose. So the current study is the first phase 3 to look at this question. This is the design of Checkmate 067. 945 patients with unresectable stage 3 or 4 melanoma were randomized 1:1:1 to either the combination of nivolumab alone, 1 milligram per kilogram, ipilimumab alone at the standard dose, together 4 times every 3 weeks, followed by nivolumab alone, or nivolumab alone with a ipilimumab matched placebo, or ipilimumab alone with a nivolumab matched placebo. These groups were stratified by PD-L1 expression, which I'll get into, BRAF status, and M stage. The co-primary endpoint that I'll be reporting on in the plenary is the progression-free survival. Overall survival, just in case anybody's going to ask, is not expected to be reported until 22 months of follow-up, so we're quite a ways away from that. Secondary endpoints include response rate, the influence of PD-L1 expression, and safety. So this is the co-primary endpoint data, which is progression-free survival. And if you look at the 3 groups, the nivolumab plus ipilimumab group had a median progression-free survival of 11.5 months. Nivolumab alone, 6.9 months, and ipilimumab...
Okay, the information was stored in my slides. Thanks.